Now, the third talk is by Dr. MANGAT DOGRA. He again needs no introduction to this audience. DOGRA was the professor of ophthalmology and vitreoretinal surgery in PGI Chandigarh, one of the premier institutes in this country. He has done a lot of fundamental work in the field of ROP and contributed a lot, especially in the field of laser photocoagulation. Dr. DOGRA.
Thank you, Dr. Lingam Gopal, for this opportunity for me. I think you have to, go to my slides, yes. So I think this has been my most favorite topic, talking for so many years all around, and this is something which is changing drastically. I do have some financial disclosures here that I've been a speaker as well as on their advisory board, some of these companies, but nothing to do with the treatment of ROP. I think laser treatment, as we know, has been a standard of care for a long time. I put it was. It is a now big question mark. It is changing. So I don't know whether it is still for all type 1, may not be. And of course, it is delivered in a confident fashion, and 90% around that would attain favorable outcome as seen in this particular case. And we did propagate, and this started from our center with the two of our publications and one way back, where I think diode laser was considered that you must buy diode. Well, there's no need. Nobody does that. I think many people now, they use the same laser which you use for, that is the green laser or 532 laser. And this is one such baby treated with the same. And there's another one you can see here, recent one. This I shared by Dr. Diksha with me. And you can see how in 10 days time, the vessels straighten up, and it's an excellent treatment. And we have done this laser for very, very long time. And another one, role of posterior barrage laser in selected cases, especially if you have something like stage 3 fibrovascular proliferation and you have 4A, and in certain situation like 4A, maybe many a time you want to avoid or the proliferation is too much, I think you can do posterior, and that is what you see here has been done, and you can see very good result in a 4A even. So I think some of these modalities, we don't have to kind of forget about them, and we don't have to be going all the way. And of course, this has been shown by Anand, we can treat through the wall of the incubator. The problem is here. Most of the ROP which we see is from outside, not in your hospital, which these babies born, and this is mostly AP-ROP in this country, aggressive posterior ROP. And they usually don't do that well. In our own series way back, it was like around 71% had a favorable outcome. We also looked at some of these factors. If you have a posterior zone 1, although this term is not used, and it's not been picked up by ICROP, but this is something where you have a very severe disease where it stops at almost fovea. This is half of what we have zone 1. And if you have a pre-existing fibrovascular proliferation, same thing happens, and you may have progression. Pre-retinal hemorrhages, or any case which will need a repeat laser. By and large, if you do good job, you don't do, but other case which is progressing, you may still find some areas and you'd like to go in, but those are the cases may have a problem and go to detachment. One of the things which we saw, this is the only first publication exclusive on posterior zone 1, and somebody call it like zone half also, that almost 79% had unfavorable outcome with laser treatment. So you can imagine if we had only to a laser in these cases, so they are mostly going to go. In fact, there are cases reported from Chile and some other places by Kinthal and other group where they had 100% unfavorable outcome in such cases. And I'll show you one such case here. You can see despite fairly good laser, ultimately in this case, this was a posterior zone 1, the stretch break develops. And what you can do now, even if you are an excellent surgeon, you put in oil or whatever, I think it will be a very difficult situation. So anti-VEGF, we have to understand now at this time, most of the AP-ROP and zone 1 ROP require anti-VEGF first. and that is accepted mostly. And this has happened after, especially already mentioned here in the keynote lecture nicely, and by the various trials. And what has happened, what we were doing earlier when we were doing a conventional laser, you see the first one, we were going inside zone 1. We did all the time. We have plenty of cases and with success. But you can see we have left just a tube there. And subsequently, what was done? The anti-VEGFs were given, the zone 1 was spared. Then it was realized that no, we can hold on, we can wait and do a laser, which is a deferred laser, which should be done much later, let the vessels grow. And so I think sometimes, you see, that is what we know now, that laser is not required if the vessels reach zone 3 or ora serrata without the reactivation. I think Anand talked about that. And ideal, as already mentioned, is deferred laser. You look up for the signs of progression and then you do it. And anti-VEGF injection will be followed by, as I said, maybe you need very less amount of laser and you will not kill that much of retina. Again, recent case shared by Dr. Diksha with me, posterior zone 1. This is what we were talking. We even suggested in that study when it was published in Canadian Journal that if we inject anti-VEGF and subsequently do a laser, deferred laser, they will do much better. So you can see here the story, what happens. This baby, 2 weeks after ILIA, then 5 weeks after ILIA, and then this is 9 weeks after ILIA. And then it is being followed, and 16 weeks after ILIA or 56 weeks of PCA. There is some progression of vascularization into the posterior zone 2. And it is very nicely seen. That is where the role of now look at the angiogram. How happy you are that it has gone much beyond, but the reactivation is happening. And so is in the other eye. Now the whole macular area is vascularized. So you are confident. I'm not even showing you subsequently the laser and other things. That is where you'll have to do laser now. And this is definitely otherwise would have led to if only the laser was done in the beginning. So I think that is where, and the combination treatment here is a deferred laser. And of course, we have now recent evidence. This is the publication you must have seen recently, just last month, in the month of April. I think this is from this big consortium of retinopathy of prematurity injection group, where it's very interesting to see that ranibizumab use was associated with a higher rate of retreatment than bevacizumab. Everybody felt, but it is now there is evidence, 58% versus 37%. The retreatment group had a larger percentage of aggressive posterior ROP. We also knew it, but now we need some evidence. And this is again 34 versus 18%. And the greater percentage of zone 1 ROP. I mean, again, we knew it, then the no treatment group. I mean, so these are all important evidences. And we also know that although we have only approval for ranibizumab, and it is available, at least in India, I believe, on Janani program, and everybody is using these days Razumab. I think you should come out with a study and from all the big hospitals. And that is something, I mean, which is a approval from DCGI. So in conclusion, what I would like to highlight about laser treatment is that laser treatment is still considered standard of care for ROP. I put a question mark. I don't know, it is not for all ROP, that is for sure. Most would use anti-VEGF first for AP-ROP and zone 1 ROP. Most. This is across the world, which I keep looking at all the publications. And anti-VEGF injection will be followed by need for less that I have shown. And that is what you don't do immediate laser. Wait. Let it vascularize. Let it, even if you see clear sign of recurrences later on, you can do that. And also, I think very nicely you had shown that the number of second injection givens are not that many. Their number is smaller as compared to the laser treatment done, which is much more. So that is also very important. And indication for needs, laser needs modification, which is going to come. It is my hunch that like in diabetic retinopathy, now laser is an adjunctive treatment. So will be for ROP down the line. It will be an adjunctive treatment. not the mainstay of treatment. That is what would happen. This is my own, just a presumption. Thank you very much.